I'd like to welcome you to the second night of our virtual edition of the Wellness Day for Women. We are happy that we could do this virtually, although it's different from our previous years, and we hopefully next year we won't have this issue. First, we'd like to thank our sponsors, and they're shown here, Our Lady of the Lake and Blue Cross have always been sponsors to this event, and we welcome People's Health as an associate sponsor. We'd also like to thank our planning committee for their support. And in just a second, we're going to have a list of those people who do sit on the committee for planning this event. You will probably remember many of them from events past. The agenda for tonight's talks are going to be a woman's life cycle of screenings presented by Dr. Terrie Thomas, who is an associate in women's health, cancer screenings, and the importance of early detection by Sobia Ozair, who is with the Breast and GYN Cancer Pavilion, down to back to basics, what you need to know to be heart smart by DeNicola, who is with the Louisiana Cardiology Associates. And finally, the last talk will be COVID-19 vaccines, facts versus fiction, presented by Sandra Brown at Southern University School of Nursing. We will have a live Q&A with each speaker after their talk, so we would invite you to submit your questions in the chat, and our moderator will read them aloud after the presentation. So without further ado, I will turn it over to Dr. Terrie Thomas from the Associates in Women's Health.
Hello, I'm Dr. Terrie Thomas. I'm an obstetrician gynecologist here in Baton Rouge, Louisiana. I'm a partner with Associates in Women's Health. We provide comprehensive obstetric and gynecologic care to both low and high-risk patients. I'm also very proud to primarily practice at Women's Hospital, a leader in excellence in women and infants health care. I am also a clinical professor for both the LSU and Tulane departments of OBGYN. I also am a clinical professor for both nurse practitioners and physician assistants. So today we are going to talk about healthcare screening. Have you ever heard the saying, do something today that your tomorrow's self will thank you for? That is the importance of healthcare screening. We are all doing something today that our tomorrow selves will thank us for. What we know is that a healthier population can lead to reductions in the cost of healthcare in the United States. When we get our mammograms and colonoscopies in a timely fashion, we are more likely to find problems at an early enough stage to intervene. In some instances, we can prevent disease or catch it at an early enough stage to do something about it in order to prolong someone's life or quality of life. So let's get started. So what are the basics of screening? Who and why? So we as healthcare professionals, be it doctors, nurses, nurse practitioners, or physician assistants, give the same test to everyone to identify those individuals at enough risk to warrant further testing or preventive action. Hopefully, before the person has developed any signs or symptoms of disease, to prevent bad things from happening. So how do we do the screening? Well, we do blood work and other tests like mammograms. We also provide counseling. So we as healthcare providers tell our patients, you need to do this or else. And then we can also provide immunizations based on your age and risk factors. So things like the flu vaccine, like healthcare workers. And then, of course, this brings to mind the COVID vaccine. So the first thing that we're going to start with is anxiety and depression. We'll start our way at the top and then work our way down. So who are we screening with anxiety and depression? We are screening adolescents, adults, pregnant women, and postpartum women. We'll focus on adolescents and adults. Pregnant and postpartum women are a special population that is beyond the scope of today's talk. We do this on a yearly basis, and we do this because anxiety and depression that is either untreated or undertreated can affect interpersonal relationships, productivity at work, or even in some instances, a decrease in the quality or a loss of life. Take, for example, domestic violence and suicide. The other reason that we are screening for anxiety is that it affects approximately 24% of women in the United States. And of course, this is twice as likely as men. And then when we look at depression, it affects about 7 to 10% of Americans. And again, women are more likely to suffer from depression than men. The things that we can do in order to improve the quality of life and prevent the further progression of anxiety and depression are counseling, behavioral therapy. So take, for example, if I have a patient that comes in saying, I have a lot of anxiety regarding that drive to work in the morning, then I'm going to coach my patient to do some things in order to reduce her anxiety. That may be leaving a little bit extra early, or drinking a nice cup of coffee or some juice in the morning, or even playing her favorite music so that it can lessen her anxiety about that drive to work in the morning. In some instances, we can even use medication. The next is domestic violence. So what do we consider domestic violence? Well, domestic violence can be physical violence, sexual violence, stalking, psychological aggression, including coercion, reproductive coercion. Reproductive coercion means that an intimate partner does something in order to sabotage the other partner's ability to either become pregnant or prevent pregnancy. It can also mean neglect or the threat of violence, abuse, or both. We usually screen both adolescents and adults, but we also pay particular attention to those at high risk for domestic violence. And this can include women that are pregnant, younger or older, those with increased stress, lesbian, gay, bisexual, transgender individuals, those with drug and alcohol misuse or dependency, former or current military servicemen and women, and then those living in an institutional setting. We do this on an annual basis. And the reason why we do this is that about 1 in 3 women are victims of physical violence. 1 in 5 women suffer from rape, and about 72% of homicides are related to domestic violence. Domestic violence can cause many traumatic side effects, such as missed work, job loss, increased risk of sexually transmitted infections, depression, and drug and alcohol addiction. Some of the things that we can do to intervene include counseling, education, harm reduction strategies such as coaching patients about how to get out of a dangerous situation, and then referral to appropriate supportive services. Next is breast cancer. So typically with breast cancer, we are screening at the earliest age 40, but at least by age 50, and at least until age 74. But this is something that you should talk to your provider about. It's a shared decision-making process between the patient and the provider. There are also some high-risk individuals. So take, for instance, there is a gene that increases the likelihood that some of us will develop breast cancer either earlier or more dangerously than others. These individuals are much more likely to develop breast cancer than the rest of the population, and so they require increased observation or screening. Those individuals are usually identified by their healthcare provider and are instructed about the necessary requirements to meet that increased screening. We usually do breast cancer screening at least every 2 years, but not more than once per year, unless the individual is considered high risk. We do this because breast cancer is actually the most common cancer for us as American women. About 1 in 8 American women will develop breast cancer in a lifetime. Things that we can do to intervene early include ultrasounds and biopsies. Next is urinary incontinence, also known as leaking urine. Some examples of urinary incontinence include urinary leakage while jumping on the trampoline with your kids, having a glass of wine and a really good laugh with a girlfriend, or sneezing repeatedly after going into the attic to put away Christmas decorations. We are typically screening adults, and some individuals are considered high risk. Anyone with a history of multiple childbirths, especially if there was a traumatic delivery, advancing age, and obesity, or some other high-risk situations. We usually screen on an annual basis, and we do this because about 50% of women in the United States are affected by urinary incontinence. And this one is actually getting worse. Some experts believe that it's probably due to the increase in diabetes and obesity. Some interventions include Kegel exercises. So that's where we coach patients on how to exercise the pelvic floor muscles in order to strengthen that area of the body. We also counsel patients on behavioral changes. That may be things like limiting fluid intake before bedtime or before physical activity. It may also include timed voiding, where we encourage patients to use the restroom on a regular enough basis so that the bladder doesn't get overly full. Sometimes we also counsel patients about medication adjustment. There are some medications that can, quote unquote, aggravate the bladder or make the bladder more unstable. So sometimes we will either change the medications or decrease the dosage. And then there's pelvic floor therapy. So there are wonderful individuals that are physical therapists that are specifically trained in improving your pelvic floor strength. There are many good clinics all over the Baton Rouge area that can help patients in this area. Cervical cancer. Just as a reminder, the cervix is that organ that sits between the uterus or the womb where we carry our babies and the vagina, which is the outlet to the outside of the world where babies are born. The patients that we usually screen for cervical cancer are women between the ages of 21 and 65. Most women remember a time when cervical cancer screening occurred on an every year basis. These days, a lot of times, we can screen patients based on age and risk factors. So take, for instance, between ages 21 and 29, we typically only screen for cervical cancer every 3 years. And then above age 30, we typically only screen for cervical cancer every 5 years. Now, of course, this can change for those women that are high risk. And this would include those individuals with HIV or human immunodeficiency virus, those that are immunocompromised, such as someone that is taking medications after an organ transplant. Also, those women that have a history of exposure to DES, or diethylstilbestrol in utero, or those with a history of treatment for cervical dysplasia or cervical abnormalities. Those are all individuals that should discuss more frequent screening with their healthcare provider. An important point to note is also that even though we are not doing pap smears every single annual visit, we still, as your gynecologist, need to see you every single year. There are so many other important aspects to an annual visit besides just screening for cervical cancer. The good news is that cervical cancer is on the decline, and it has been this way for about the last 40 years in the United States. Outside of the United States, cervical cancer is still a pretty significant problem. But here in the United States, when women get pap smears on an annual or semi-annual basis, or every 3 to 5 years, those women usually can get their abnormalities detected and treated before they progress into something more serious. Another good reason for screening for cervical cancer, particularly, is that early detection is very good with cervical cancer, in that cervical cancer, when it's detected early, is very treatable and can be associated with long survival. Some of the interventions that we use include colposcopy, which means that the healthcare provider examines the cervix very closely with a microscope, and then also LEAP surgery. So LEAP is where a biopsy of abnormal cells are taken of the cervix, and all of the abnormalities are removed so that hopefully the patient can start out anew. HIV. We are typically screening adolescents and adults and all pregnant women. We usually do this on an annual basis. And we usually pay particular attention to education and risk assessment. We usually provide a lot of information about those risk reduction strategies, like decreasing the number of sexual partners, not using IV drugs, and other things that can help to reduce someone's risk. Those that are high risk include active injection drug users, those that have unprotected vaginal or anal intercourse, those having multiple sexual partners, those people that are initiating a new sexual relationship, those with sexual partners who are HIV infected, bisexual individuals, individuals that are injection drug users, those that exchange sex for drugs or money, those women that are victims of sex trafficking, those individuals that have been incarcerated either currently or previously, and those that have other sexually transmitted infections. The reason why is that HIV is prevalent. In 2018, Georgia, Florida, and Louisiana had the highest rates of new HIV diagnoses in the United States. Some things that we can do to intervene include improving treatment outcomes and, of course, reducing transmission to other people. Osteoporosis. Just as a reminder, we are constantly in a mode of remodeling for our bones. We're constantly breaking down bone and building new bone. Osteoporosis occurs when bone loss outweighs bone rebuilding. We are typically screening those individuals greater than 65 years old. However, those that are high risk and less than 65 also need to be screened. High-risk individuals at less than 65 can include those with a medical history of a fragility fracture, those with body weight less than 127 pounds, those with medical causes of bone loss, such as taking medications or certain diseases that can decrease bone density, those with a history of parental medical hip fracture, current smokers, those affected by alcoholism, and rheumatoid arthritis. We usually screen every 2 years at most, but some individuals should talk to their providers about more frequent screening. The reason why we screen for osteoporosis is that it affects over 50% of adults over age 50 in the United States, and it represents economic impacts of tens of billions of dollars in terms of paying for osteoporosis-related fractures. The sad thing is only about 56% of women walk independently after hip fractures, and about 3 to 6% of women die after hospitalization for hip fracture. Some of the interventions that we can do as healthcare providers include encouraging physical activity, which improves muscle and bone strength, good nutrition that includes all of the essential nutrients, especially calcium and vitamin D, which are important for bone development, and then fall prevention. So we usually counsel patients about removing any loose rugs, having good lighting in their homes, and then outside of the home, making sure that patients are not engaging in risky behavior like walking and texting, not paying attention to where they're going, or other behaviors that can lead to falls. And then there's special populations. So even though these populations are outside of today's talk, I definitely wanted to pay them some attention. So for pregnant and postpartum women, we usually are very focused on providing them with breastfeeding, resources, and encouragement. And then we're also interested in screening and trying to prevent gestational diabetes. And then for our general populations, we are particularly interested in preventing and coaching about risk reduction strategies for sexually transmitted infections. Thank you so much for your attention. And remember, do something today that your tomorrow self will thank you for.
Thank you, Dr. Thomas. While we start the Q&A, we want to take a moment to acknowledge our sponsors again. If you would like to visit their websites, you can direct your camera on your on your smartphone towards the QR code to be directed to their websites, or type the links listed here into your browser. I believe that Julie will read the questions.
Thank you again, Dr. Thomas. We do have 2 questions so far in the chat, and if anyone else would like to submit any, please go ahead and type them into the chat and I'll read them out loud. First, how much worse is the anxiety and depression due to the pandemic compared to previous times?
I can't give you an exact number because a lot of those numbers are still being studied, but certainly it has increased significantly. So we've seen everything from anxiety and depression all the way to intimate partner violence. We've had some statistics that has increased significantly. I can tell you, for me personally, in seeing my patients, some of it has been very disheartening. My visits that were once 5 or 10 minutes in length, a quick little, pap smear and hello, how you doing? Where are you going on vacation? What's going on in your life? Have become longer conversations that sometimes delve into some pretty heavy topics like, I know of 3 or 5 people, either from friends or personally with family members, that have been affected by deaths due to COVID. And then other things like, some people don't do so well with the isolation of the pandemic. So I spent a lot of time coaching patients about feeling safe enough to go outside their homes and get some fresh air and some sunshine, at least for 30 minutes a day. And this is very important, especially when many people are working solely from home or educating their children from home. So I've tried to stress the importance of trying to maintain as much normalcy as possible during these difficult times. And hopefully, if we can get enough of the population vaccinated, we can really start to open some things up and get back to some semblance of normalcy. I heard some interesting statistics today just on the way here that only about 14% of Louisianians have received at least one vaccination shot. What I hear from patients a lot is that I'm going to wait to see how other people do, or I'm going to depend on other people to get vaccinated. But what people don't realize is that about 70 to 80% of the population will have to be vaccinated before we can get back to any semblance of normalcy. So I know that was off topic a little bit, but I just wanted to give a little push to say, yes, things are worse than they used to be, but in order to get back to something better, we're going to have to bite the bullet and get that shot, or 2 shots as the case may be.
Thank you. Our next question that we had is, what are the contributing factors that are attributed to women being at a higher risk than men for anxiety and depression? And is there a difference in rates between white and non-white women?
Absolutely. Absolutely. And I think a lot of it, some of it has to do with the way that we deal with stress, certainly. Some of us tend to internalize things more than others and bury it down deep and not really talk about it. Some people tend to not ask for help. That's another reason. Many women I find, they call themselves worriers. I myself am guilty of that. We worry. Sometimes we are maybe a little bit more fearful about hurting feelings and speaking up for ourselves. There was some research done that women are much more likely, in terms of things like just simply asking for a raise, that women are much more likely to ask for things for their family members or their friends or even coworkers before they'll ask for things for themselves. So I think it's a multitude of things. And then certainly, individuals of a lesser socioeconomic status, those individuals that are of minority groups, suffer with way more anxiety and depression than non-minority groups. That's well documented. And again, that's due to a multitude of reasons, everything ranging from poor access to medical care to poor housing conditions, and then of course, lower incomes.
And then our next question that we had, they would like your opinion on pap smears for women over 65 who have had a vaginal hysterectomy and have been celibate for decades.
Don't do it. Don't put yourself through it. So, we as women go through enough. So certainly if, I do have some patients that have been getting their annual pap smears for such a long time, it's just a habit for them. And so, at this point in time, there are some insurance companies that will only pay for a pap smear every 2 years. I do have some patients that say my insurance company will pay for it, so I want my pap smear. Or I even have some patients that say, I will pay for the pap smear myself. That's just what I'm comfortable with. But, all of our current research shows that 65 is really a good time to stop doing those pap smears. Especially if the cervix has been removed, and that's something that you would know from the physician that performed your hysterectomy. So my advice would be, it's one less thing that you have to worry about, and so just live your life and follow the guidelines and the research. It's there to help you and to guide your practitioners to keep you safe.
And our next question is, what about an increase in diseases associated with the fact that people didn't get screening due to COVID? Have you seen more of that?
I'm sorry, could you repeat the question?
Yes. What about an increase in diseases associated with the fact that people aren't getting screenings due to COVID? Are you seeing more of that?
Well, so luckily we did see, and again, sometimes it takes us a long time to get statistics on things like that. So some of those studies are still in progress now. There was a point in time when at the very beginning of the pandemic, we shut everything down. We were only doing and offering emergency services. So we were only doing emergency surgery. We were not even doing pap smears or mammograms. So I think with time, we will see that the other point is that there are some individuals that are simply afraid to come to the office and get those preventive services. So I think when we look in retrospect, we will see, unfortunately, some increases in things, in diseases and cancers that could have been prevented with the appropriate screening tests. But it's probably a little too early right now to get a good grasp of those numbers.
All right, that was our last question. Thank you very much, Dr. Thomas. I really appreciate you joining us tonight, and that was a great presentation that I know everyone enjoyed.
Great, thank you, Julie, so much. I so enjoy working with Pennington, and thank you so much to you guys for raising awareness and in your efforts to keep our community safe.
Thank you. Up next, we will have a short presentation from Dr. Sobia Ozair of the Breast and GYN Cancer Pavilion.
I am Dr. Sobia Ozair, and I work at the Breast GYN Cancer Pavilion, a partnership between Mary Bird Perkins Arleta Lake Cancer Center and Women's Hospital. Education and early detection are an important part of screening for women because early detection is key because it can help prevent a disease from developing. Many cancers are actually preventable, and when they're found in an early stage, they're very treatable. The chances of survival exponentially increase when a cancer is found early. It's very important during the pandemic that we don't delay our screening tests, like your mammograms and your colonoscopies. That's why we encourage you to contact your providers and get back in and get those tests rescheduled. We also encourage you to utilize the Mary Bird Perkins free screening program. If you visit marybird.org, you can actually look through a list of all the free screening programs throughout the region. Worldwide, breast cancer is the leading cause of death in women. In the United States, it's the leading cause of cancer. Important things that you should know for early detection of breast cancer is to actually utilize those tests that we have available. One of the best validated screening tools we have is a mammogram. Mammograms are important because you can actually catch cancers very early. It's also important to be familiar with your family history. A family history of breast cancers or even ovarian cancers can mean that you may have a predisposition to cancer itself. So it's very important to be aware of your family history, discuss it with your doctor. That may mean that you need to get genetic screening tests or mammograms more often. Together with Women's Hospital, we provide screening for women for breast cancer. To learn more about that, you can go to breastandgynecancer.org. Women can get breast cancer screening in their early 20s. They can get a clinical breast exam every 3 years by their primary care physician. When they turn 40, it's recommended that they get an annual clinical breast exam and mammogram yearly. You can also be proactive and start doing self-breast exams at age 20. It's important to know your body because if you do find something abnormal on yourself, you can bring it to clinical attention. Cervical cancer screening is very important because, again, early detection is key. That's the best way to get cured if you are diagnosed with a cervical cancer early. One of the most important things about cervical cancer is that previously in the United States, it used to be the leading cause of cancer death. However, over the last 30 years, that rate has decreased by 50% because of the advent of the Pap test. Louisiana, unfortunately, is leading in a negative way. It actually has the highest incidence of cervical cancer. This year, it's predicted to have 240 new diagnoses of cervical cancer and 80 deaths from cervical cancer. Another reason why it's so important to get those Pap tests. All women should get cervical cancer screening starting at the age of 21. Women between the ages of 21 and 29 should get Pap smears or Pap tests every 3 years. A woman between the ages of 30 and 65 should get a Pap test and HPV test every 5 years. However, if it's a woman who has a higher risk of cervical cancer, they may need to get these tests more frequently. That would be a discussion between the patient and their doctor. Another point to mention is although we have this great vaccine called the HPV vaccine, it does not mean you do not follow these guidelines and not get Pap tests. Although the vaccine is very effective in protecting against the most common types of human papillomaviruses, or HPV, it does not protect against all types of HPV. There are actually over 170 types of HPV out there. So it's very important to get your screening test done. Colorectal cancer is the second most common cause this cancer can be diagnosed in later stages, which is why the colonoscopy is so important as a screening test. You may not have symptoms until it's too late. Colonoscopy is a pretty simple and painless test. You come in for an outpatient procedure and a doctor actually takes a look at your colon up close and personal and sees if there's any polyps or precancerous lesions to be removed. They're actually able to remove those lesions at that time, in a way preventing cancer from actually growing. The good news is that 90% of these cancers, when they're diagnosed in early stage, are curable. The Cancer Center's Prevention on the Go program offers free take-home kits that you can do at home. This is not a colonoscopy, but can still be used for screening purposes. As I said earlier, colonoscopies are now recommended at age 45 for men and women. Before, it was recommended at age 50. Interestingly, a study was done that found that patients who were born after 1990 were actually 4 times more likely to have colon cancer, which is why the American Cancer Society made that change in the recommendations for colonoscopies to actually start at age 45 and not at 50. You may need to be tested earlier or more frequently for several reasons. One, if you have a history of colorectal polyps, you may need to get tested sooner. If you have a family history of a genetic syndrome or a family history of colon cancer in a close relative, you also may need to be tested sooner. Another reason to be tested sooner is if you have inflammatory bowel disease, such as ulcerative colitis or Crohn's disease. If you meet any of these criteria, and it sounds like it pertains to you, it would be a discussion you definitely want to have with your doctor to find what's right for you. Lung cancer screening is also very important for women because right now in the United States, it's the #1 cause of death. It is also the second most common cause of cancer. Lung cancer screening is recommended in both men and women between the ages of 55 and 80 if they have smoked a pack of cigarettes at least for 30 years and currently smoking or had quit in the past 15 years. Lung cancer screening test basically is a low-dose CT scan. After you get your scan done, the doctor would discuss with you a plan of action based on what the findings are. If there is a lung nodule found, typically a biopsy is recommended. The question is, where do you go when you get a new cancer diagnosis? The Breast and GYN Cancer Pavilion is a unique facility that's solely dedicated to treating women with breast and gynecologic cancers. Mary Bird Perkins, Our Lady of the Lake Cancer Center, and Women's Hospital work side by side in bringing the best possible care for their patients. They have the most experienced doctors and the best possible treatments, including access to national clinical trials. To learn more about the Pavilion, you can go to breastandgyncancer.org. To learn more about colon cancer and lung cancer, you can visit marybirdlake.org. Thank you for listening to this presentation for Pennington's Wellness Day for Women. I look forward to chatting with you in the Q&A session coming up next.
Thank you, Dr. Ozair. While Julie gathers your questions for the Q&A, I wanted to share this slide. Pennington Biomedical is currently seeking participants for a variety of research studies, and you can go to the link listed here, pbrc.edu/healthierla, for more information on the studies or how you can get involved. So, Julie, do we have any questions?
Yes, our first question from the chat is it significant to get a 3D view mammogram over the regular method of mammogram screening?
So when you first start getting your mammograms and you turn 40 and it's that time, you actually will start off with a screening mammogram. If it's indicated that you need to get a diagnostic mammogram, that will be determined when you get your screening mammogram done.
Thank you. Our next question, if you have polyps, how frequently should you get a colonoscopy?
So it depends on what kind of polyp, how many polyps, and that will be a discussion with your gastroenterologist. So it really is going to be a case by case scenario depending on what the polyp, how big it was. So for instance, if you have a polyp that looks very suspicious, they might remove it and say that you need to come back in a year. Sometimes you can have a polyp removed, but it seems mostly benign and they might have you come back in 3 to 5 years. So it will depend on what your gastroenterologist recommends and what the pathology shows.
At what age are you supposed to start getting colonoscopies?
Right now, the current recommendation for colonoscopies is 45. It used to actually be 50, but the recommendation changed because the average age of colon cancer diagnosis has actually decreased. So now you should actually start at age 45, but it was 50 previously for men and women.
Can you please explain the difference between a screening and diagnostic mammogram?
So a screening mammogram is not going to be, a diagnostic mammogram is actually going to just be more specific and more detailed images of the breast. So if a screening mammogram sees something, it just may not be able to clarify if it looks cancerous or not, and it just may say that it looks suspicious, but a diagnostic mammogram is going to be the step further of taking a closer look.
Is the women's mammogram bus currently taking patients?
I actually will not know that answer right now. I know on the website, marybirdlake.org, you can actually look up what days they are available and when they're going to be getting patients in for the screening. But I don't know specifically what days right now, especially with the ice storm that had come in last week.
All right, that is all the questions that we have for today. Thank you so much, Dr. Ozair. We really appreciate it.
No
And
problem. Thank you.
up next, we will have DeNicola help us learn about how to be heart smart.
Hi, good evening. My name is DeNicola. I am a nurse practitioner at Louisiana Cardiology Associates. I've been a nurse for, I guess it'll be 22 years in May. I've always done cardiology. The majority of my career has been at Our Lady of the Lake, and I've been at Louisiana Cardiology for approximately 7 years. This is a topic that is near and dear to my heart, and I'm so glad that I was asked to kind of come on here and talk a little bit about women's heart health. There's a lot of things in the news, about health and wellness and this and that, and a lot of it can be contraindicating. And I just really wanted to kind of get back to basics and talk about a few things that I think are important for you to know to stay heart healthy. So, women and heart disease. The one thing that hasn't changed, unfortunately, is that heart disease is the #1 leading killer of women. Above breast cancer, above any kind of cancer, is the #1 killer of women. It has a lot to do with our lifestyle, how we live, how we choose to live, how we take care of ourselves. Differences in treatment as compared to men. We'll talk about this a little bit. I think that providers don't set out to treat women differently than men, but because of coexisting comorbidities and other things, sometimes the treatments just vary. Also, differences in testing when diagnostic testing is done or when it's chosen to be not done can vary with women. Hormones. Hormones play a big part in our cardiovascular risk, and we'll talk about that a little bit as well. The one thing that I think it's important that I want you to walk away with today is differing presentation and symptoms of women. We're different. Our bodies are different. Our our minds work a little bit different, and how we present with heart attack or other coronary problems can be very different than a man's presentation. So it's important that we pay attention to our bodies and what's going on. And that will kind of bring us to my first real topic, is going to be menopause. Important to know that menopause in and of itself does not cause coronary artery disease. I will tell y'all I have some notes because I want to make sure speaking virtually is a little bit different. So I want to make sure I don't miss any of the high points. Menopause does not cause coronary artery disease in and of itself. The average age of menopause in women is 54. I'm sure that some of you could talk about early onset menopause, and some of you were much later. Honestly, I'm 47, and I'm pretty sure it's not far away. It varies for every woman. Overall, heart attacks increase at that 10th year after menopause begins. So just the incidence in general of heart attacks in women is going to be a higher incidence when they hit that 10-year mark after menopause. So you're looking at 64, 65, and older. Why? There's a couple of reasons why we think this happens. Estrogen is good for the heart. So estrogen can have positive effects on the lining in the interior of blood vessels. It makes them more flexible. So when we have a decrease in estrogen, like we see with menopause, our vessels can become less pliable and more stiff, which can lend itself to coronary disease. We've heard in the past about hormone replacement therapy, and one would think, well, if estrogen is good, then it must be important to replace it. Not necessarily the case. Hormone replacement therapy can be detrimental and increase risk for coronary artery disease. However, this is a conversation that you have to have with your doctor. It doesn't mean that you can never have hormone replacement. It simply means that there's a risk and a benefit with everything. And you really need to sit down with your gynecologist, heart doctor, primary care doctor, and talk about the benefits and the risk. If you're having a lot of symptoms, it might be worth the risk for you, if your risk factors are otherwise low, to go ahead and get the hormone replacement therapy. Excuse me. Blood pressure can also go up during menopause. We're going to talk a little bit more about blood pressure towards the end, but this is a time when you do need to know what your baseline blood pressure is if you didn't beforehand, and kind of just take general readings on occasion just to watch for trends and make sure that this is not elevating. Cholesterol can also elevate during menopause and after, so another thing to be mindful of. You hear it all the time: regular exercise, a balanced diet, no smoking. These are things, obviously, that we have control over. There's so many things that we don't have control over. Moving our bodies as much as we can, making sure that what we're eating is balanced. Leaner meats, more fruits, more vegetables, less dense carbohydrates. That's going to be important. And of course, no smoking. All right, diabetes. I feel like diabetes is just a very common factor in a lot of our heart patients and a lot of our patients in the area in general. So diabetes, what is it? It is a disease where insulin is either not produced or is not used efficiently by the body, which results in elevated blood sugars. So this can lead to many issues when untreated, including cardiovascular disease. If you think about patients with diabetes, and I'm sure some of you listening either have diabetes or know someone who does. If you think about it, what are some of the recommendations? We talk about getting your eyes checked once a year. We talk about being very careful with foot care, whether you're clipping your toenails, we say don't walk barefoot, and that's because of neuropathy. Why is that? Well, that's because diabetes can have a detrimental effect on vessels in the body. And the smaller the vessel, the easier these symptoms are going to be to find. So you have a loss of vision with untreated diabetes, and you can also have peripheral neuropathy either in the feet, the hands, or both. Excuse me. The vessels of the heart are vessels just like vessels in the eye or hands and feet. They're just bigger, right? So it stands to reason that diabetes can also wreak a little bit of havoc in the larger vessels of the body. If a patient has diabetes, you are at as much risk for a heart attack as someone who had a heart attack already. You are treated by a cardiologist as someone who has heart disease. What does that mean? That means that there are certain medications that are standard that you should be on. Your cholesterol should be at goal, which would be about 60 for the LDL. We typically make sure, the blood pressure is under better control. We use medications that are heart protective, like beta blockers, simply because you have diabetes and you have that increased risk. Women with diabetes are at greater risk for cardiovascular disease, than men, like a twofold greater risk than men. Studies show that women are less likely to get cholesterol medicines as early as men do. If you have diabetes and you are not on a statin, you should be. If you can't take a statin, it should be a conversation you have with your doctor about making sure we're doing something else to keep your cholesterol down. Women are less likely to get other heart protective meds, which we talked about. And we talked a little bit earlier about the difference in women and men's treatment. These are just two of the ways that can vary. Studies just show that providers are less likely to put women on those as soon as they do with men. Other factors that increase risk in women, we have a higher tendency of having comorbid conditions when we're diagnosed with diabetes, such as already having hypertension, already having high blood pressure, abdominal obesity, which is a ever increasing problem. And also women with diabetes have higher inflammatory responses in vessels than men do. And we know now that a lot of our risk comes from inflammation in the vessels. So it's really important that if you do have diabetes, that your hemoglobin A1C is checked by your primary care or your endocrinologist on a regular basis. 6.5 or less is going to be well managed. And if you have diabetes, it's imperative that you have an open conversation with your doctor about primary risk for cardiovascular disease. Okay, we'll talk a little bit about blood pressure. And, blood pressure is a common denominator in many, many comorbidities, right? Whether you have vascular disease, kidney disease, diabetes, strokes, blood pressure plays a big role in a lot of these. So it's really important for me that you understand this basic screening procedure and exactly what we're looking for and when to talk to your physician. So what is elevated blood pressure? We hear different numbers. Your doctors and providers will probably give you one to the next. They'll give you probably a varying degree of numbers. My numbers come from American Heart Association. That's where I'm getting a lot of my information because they really are a great source of solid, fact-based, research-found information. So your systolic is your top number, your diastolic is your bottom number. Normal textbook is going to be less than 120 systolic pressure and less than 80 diastolic pressure. Now, when we talk about blood pressures, we always talk in trends. There is no one person whose blood pressure is the same every time it's checked from day to day. No matter if you check at the same time of day, things vary depending on your emotions, what you've been doing, what you've been drinking and eating, the weather. I think everybody's blood pressure was probably a little higher than normal over the last week. An elevated blood pressure is going to be a blood pressure that's 120 to 129 on the systolic end or the top end, and 80 or less than 80 on the bottom. Hypertension stage one would be your blood pressure that's 130 to 139 on the top, or 80 to 89 on the bottom. It could be both together. It could be just one of those. If you're 128 but you're running 89 on the bottom, that's considered stage 1 hypertension. Stage 2 hypertension is 140 or greater for your systolic pressure and 90 or above, or 90 and above on your diastolic pressure. And a hypertensive crisis is defined as systolic pressure greater than 180 or on the top, systolic greater than 180 or diastolic greater than 120. When you have hypertensive crisis, this is when you worry about strokes. You may have loss of vision. These are going to be emergencies that you need to seek help for right away. I'll get a little bit more into that towards the end. When should you check your blood pressure? So if you are going through menopause, you should check it on occasion. Even if you don't have high blood pressure, if you're diabetic, you should check it on occasion. I'm a firm believer that once we get older, we should kind of know what our blood pressure runs, just so we can find the trends and know if it's getting high or if it's running too low. If you do have high blood pressure and you take high blood pressure medication, you should really check your blood pressure several times a week. If you have stable pressures, then you don't need to check it every day. But what you're looking for is if you see a doctor every 4 months, you want to know if that pressure is going up in that 4-month period, because what we want to keep away from is an extended period of time when the blood pressure was uncontrolled. So it's a good idea to monitor and recognize your trends by keeping a log that you can bring to all your doctor's office visits. So when you check your blood pressure, you want to be still. You want to have not had caffeine, not had any exercise, no smoking within about 30 minutes. Sit down correctly, which means in a chair that supports your back, that you have the chair under your legs, your feet are flat on the ground. If you're lying in bed, like if you were in the hospital, your feet should not be crossed. They should not be crossed below you if you're sitting either. It's a good idea to check at the same time every day, although we a lot of times will tell people, they say, well, I can't check it at the same time every day. I'd rather you check it at varying times than not checking it at all. If you take medicine, it's imperative that you check your blood pressure, that you wait at least an hour after taking medicines, because what we look for is your blood pressure with the effect of the medicine in your system. So we would need to know, have you taken the medicine, let it get into your system, which is at least an hour, and then check your blood pressure. Some people come in to our office and say they've been told to take 3 readings and use an average. We typically will ask you just to take 1 reading, and again, we're looking at trends, so you have 7 readings in a week that we can kind of base things off of, and that will typically, those will even out. When you're picking a cuff, wrist cuffs and finger cuffs are not recommended. They're very inconsistent and do not give us really a good idea of your blood pressure reading. You don't need the most expensive. I usually say the middle of the road blood pressure cuff is just fine. Get one that fits your arm appropriately. If it's too big, you'll get a low reading. If it's too tight or too small, you will get an incorrectly high reading. Once you get it, next time you go to the doctor's office, bring it with you so they can correlate it with the pressure that they take to make sure that it's giving us good pressures that we can trust. A couple more things about blood pressure. Birth control. Oops. Sorry, y'all. Birth control, taking birth control pills, hormone pills, or any kind of birth control really, can increase your blood pressure. So you want to be sure if you're going to start taking these medicines, that you have a good baseline for your blood pressure and that you speak to your doctor beforehand if you already have elevated blood pressure. Pregnancy can affect blood pressure. There are a lot of things, preeclampsia, things like this that really have to be watched if your blood pressure is getting too high when you're pregnant. So you should know a good baseline blood pressure prior to pregnancy so you'll be able to monitor it. Good control prior to pregnancy, limiting sodium, staying as active as you can, and quitting smoking are some of the most important things that you can do. Special considerations in regard to medications for high blood pressure would be most definitely pregnancy, breastfeeding, and also menopause. And we talked a little bit about, whenever we discussed menopause, that this can be elevated, blood pressure can be elevated when you begin menopause and as you go through it. So that is it on blood pressure. The other, just real quick, I'll say, uncontrolled blood pressure over time can lead to heart failure, stiff heart muscle, which leads to heart failure. It can also lead to kidney disease, and these are end organ damage. So these are organs that get damaged because the blood pressures in the body are too high. And I tell you that just to let you know that it's super important that it's just something that you're always kind of keeping an eye on and not letting fall by the wayside. I just wanted to, my sources are easy. Heart.org is the American Heart Association's website. You can go there and search on anything that you're curious about, and they're going to have an answer for you. I would encourage you to go to heart.org and get more information on Go Red for Women, which is our initiative, American Heart's initiative to educate women on heart disease. The Capital Area Heart Walk this year is going to be in April. It's April 10th, and it's digital. Thank you, COVID. You can walk wherever you are. So, you could get a team of friends together in your neighborhood, and what you do is you walk and you log your miles. And if you get sponsors, then you can go there to heart.org and donate your money for American Heart Society as well. I hope that I have given you some good information. Some of it's repetitive, but that's how we learn, right? Is hearing the important stuff more than once. I think we're going to have a question and answer session after we're finished, so I'll be able to answer any questions that you may have. I hope y'all have a great night and be blessed.
Thank you, Dawn. While we gather questions for Dawn, we also wanted to let you know that Our Lady of the Lake is currently offering COVID-19 vaccines in the conference center at the Pennington Biomedical Research Center for those who meet the current eligibility criteria. So to see if you are eligible or to make an appointment, you need to visit the link that's listed here on the slide at the bottom, the fmolhs.org and all the rest of that stuff that's there. Julie actually just put it in the chat, so that you don't have to write it down. And so now we will have Julie reading the questions that have been posted in the chat.
Thank you, Kathy. Our first question, I'm on 2 blood pressure meds. My pressure fluctuates from a high of 150/83 when I first wake up to a low of 123/77 after taking meds. Should I be concerned?
So it's important to remember that if you have high blood pressure, if you take meds once a day, and I'm assuming it sounds like you take meds in the morning, those are going to last about 24 hours, right? So you take them in the morning and you have good blood pressure response all day. In the evening through the night, that starts to wear down, and that medicine is at its kind of end of its effect by the time you're waking up and checking your blood pressure again. So your blood pressure is really going to be at its highest right before you take your medicine. Unless you're having a problem with lows, I usually tell people I wouldn't even take it before you take your blood pressure medicine, because we know it's going to be high, right? Take your blood pressure medicine, wait an hour or two, then check your blood pressure, and then you can see how your blood pressure is running with the effects of the medicine in your system. Does that make sense?
I think it does. Our next question is, how different is taking blood pressure with the wrist cuff than an arm cuff? This person has a wrist cuff. That's a really, really good question. I guess the easiest answer is something is better than nothing. But we find that the wrist cuffs, and there's even finger cuffs, we find that those can be very inconsistent.
I personally believe it's because there's less pliability in the wrist. Okay, it's mostly bone, and I just find that there's interference. If that's all someone has and they cannot afford to get another one or don't have means to get another one, I tell them that it's a good guide for us. You may run a little higher on that cuff than you would a regular cuff, but it can at least tell you if you're going up or down. So the cuff that goes on your arm, the upper arm, is going to be the most accurate cuff that you can get, is the answer to that question.
Thank you. Our next question is it more important to take the baby aspirin in the morning or at night?
It does not matter nary a bit. It's a 24-hour medication. I think usually we tell people, I think most people take aspirin in the morning with their morning meds. If you only take meds at night and it's a matter of remembering, I say it's more important to remember it every night. So take it with the rest of your medicines.
Sorry, I forgot to unmute myself. Our next question, diabetes and blood pressure seem to be key factors in the pandemic, but is that related to obesity, or would someone who had those and not be obese be less at risk?
One more time. I'm sorry. There was a lot there.
Diabetes and blood pressure seem to be key factors in the pandemic, but is that related to obesity, or would someone who had those and not be obese be less at risk?
No, I mean, I certainly think that if you are diabetic and have high blood pressure and obesity, you're going to be at higher risk, just because obesity is going to lend to more poorly controlled diabetes, or can lend to more poorly controlled diabetes, and more difficult to control blood pressure. But if you have diabetes and high blood pressure, you're at high risk for heart disease.
What is the right blood pressure for aging individuals? I hear higher than 120 or over 80 is okay, but recently I heard that older individuals should go for 110 over 70.
So, my biggest concern with older individuals is always a blood pressure that is too low. Ideally, we used to say if you're older, it's okay to have a blood pressure 140s, and that's all right. But typically we're really looking for that less than 120, less than 80 for most age groups. Here's the exception. If you have someone who is older, might be a little weaker, they get dizziness, it's really important. They may need a blood pressure that rides much higher to prevent those dizzy spells, because the most detrimental thing for them could be a fall. So if I have patients that really feel crummy when their blood pressure is less than 130, I'll let them be 150 all day long to prevent a fall that might break a hip, hit their head, cause a stroke, something of that nature. So it's pretty individual, but ideally, yes, we're still looking for that lower pressure.
What is the best blood pressure medicine? Some make you cough.
So ACE inhibitors are the medication class that are famous or infamous for making someone cough. Not everybody. It's certainly, they are excellent drugs. Those are drugs that are super important if you have diabetes. There's a cousin to that, which are the ARBs. The ACEs are the lisinopril, benazepril, fosanapril, the prils. Those can cause cough. The cousin to them, the ARBs, like the valsartan, losartan, those sometimes can cause a cough, but it's rare. And those are excellent blood pressure medications. So I can't say that there's one blood pressure medicine that is the best. We typically have guidelines as to when someone is first diagnosed with blood pressure, we may start a beta blocker first. If that doesn't work, we might try a fluid pill and then an ACE or an ARB. But it also depends on if you have comorbidities. If you have diabetes, we're going to put you on that ACE inhibitor first. We know that we have blood pressure medicines that do other things. They help heart failure. They help protect kidneys and diabetes. So it's very dependent on what other diagnoses you have.
They sent a follow-up question. What about amlodipine?
Amlodipine mesylate. So that's a really good Amlodipine is a really good blood pressure medicine. It works a lot on the diastolic pressure, that bottom number. It ranges from 2.5 to 10 milligrams. The one thing that a lot of people don't like about amlodipine is it can cause swelling in the legs. It's usually at the higher dose of 10 milligrams, but a lot of times amlodipine is going to be one that we add on if we need help with some of those other ones, because it, like metoprolol and beta blockers, they are heart protective and they help your blood pressure. The lisinopril, those can help with heart failure and protect your kidneys with diabetes. Amlodipine really only helps blood pressure. So it's not the most beneficial because it doesn't do the most good things for you, if that makes sense. But it is a very good blood pressure medicine and we use it all the time.
We also had a question, can I take my Claritin or Zyrtec at the same time I take my blood pressure medicine?
Yeah, that's not a problem. But that's I'm glad that you asked that question. It's important to remember, especially as we're coming up on spring, over-the-counter medicines can affect your blood pressure. Claritin D, Zyrtec D, Allegra D, those with that D behind it can drive your pressure up. So I just tell people stay away from the D. But anytime you're taking over the counters, you want to be sure that you are watching your blood pressure. But Claritin's a safe drug with blood pressure. It doesn't really affect it too much. And yes, you can take it at the same time.
So if it is onset by obesity or menopause, are those blood pressure medicines something I have to take forever?
It's a good question. If you have high blood pressure and you are obese, when you start to lose weight, you will require less blood pressure control. It's beautiful to watch. It's satisfying for us and of course for the patients as well, when they decide to embark on that weight loss journey, right? As they check their blood pressure, like they'll call and say, man, my blood pressure is running so much lower. We're like, okay, let's cut this medicine in half. And we can continue to do that. Doesn't mean we'll get off of everything, but there's a lot of things that we may be able to potentially get off of with the weight loss. Menopause, my go-to answer with that is it kind of depends, because as we get older, we have a tendency for high blood pressure anyway. But sometimes after that initial going through menopause and the stress of that, blood pressure can start to even out.
Any insight on taking Zyrtec for hot flashes? Seems to be the only thing that helps. Got it from a midlife Facebook group. What is the science?
Not my wheelhouse. I don't have the answer to that one at all. I say if it works, Zyrtec's a pretty safe drug.
And then another question, is it okay to try and wean yourself off of blood pressure medicine?
Under the advisement of your physician, yes. I mean, we wean people off all the time. They'll call and say, hey, can I try this? Sure. But it's important to, I find it's important to do that as a group project with your provider. That way, if there's problems, we know exactly what you've been taking. We can adjust your list. So there's never a question when you call and you're having an issue. We know exactly what regimen you've been on. But we're happy to work with you on those things.
All right. And we had another question about the blood pressure cuff. Is the lower arm acceptable if you live alone and cannot get the cuff on the upper arm?
Yes. Yes. Again, something is better than nothing. So I'd say if we know that it's going to run 10 points higher on that lower arm, that's okay. But I'm going to know it if your blood pressure starts rising though anyway, correct? Even if it's, because you're comparing apples to apples. So yes.
And then our last question, are there any medications that counteract the effects of blood pressure medications?
Over-the-counter medications counteract blood pressure medications. I will say this because I'm dealing with this with my dad. 2-day prostate medication, and that's not this this population that I'm speaking to, but prostate medications can lower blood pressure, so that can have an effect on blood pressure medicines. That's the over-the-counters are really what comes to mind ADHD medications can affect blood pressure and heart rate as well.
Thank you so much, Dawn. We had a lot of excellent questions.
Those were some really good questions. Thank y'all.
Up next, we have Dr. Sandra Brown, who will join us to help us all better understand the facts about the COVID-19 vaccine.
Well, hello, everyone. My name is Sandra Brown. I serve as the Dean of the College of Nursing and Allied Health at Southern University and A&M College in Baton Rouge, Louisiana. I also serve as the co-chair of the Louisiana COVID-19 Health Equity Task Force appointed by Governor John Bel Edwards. It is indeed a pleasure to be here with you this evening. Our goal from this presentation is to present to you the facts versus fiction as it relates to the COVID-19 vaccine so that you can make an informed decision about the vaccine based on science. So our first fact that we want to communicate tonight is the COVID-19 vaccine safe? And the facts are that rigorous testing processes were used to develop the vaccine. There's some concern that the vaccine was developed so quickly. And we just want to emphasize that there was already research underway as it relates to the coronavirus. The coronavirus is nothing new. So scientists had been studying this virus for years. They already had existing data on the structure and the life cycle of this virus. There was worldwide collaboration in the clinical trials where knowledge was shared. And there was funding to support the production of and development of the vaccine, both from the government and from private sectors. And all of this helped to expedite the process time that is required for FDA approval. Will the COVID-19 vaccine alter my DNA? So the vaccines that are used, the COVID-19 vaccines, both the Moderna and the Pfizer, are what we call mRNA vaccines. This is messenger RNA vaccines. They're not live viruses, so they can't cause COVID-19. The messenger RNA allows the body's own cells to target the coronavirus spike protein. So if you look at the protein that's in the left side of this picture here, you'll see little spikes jutting out of it. Well, the messenger RNA allows the body to target those spikes so that an immune response can be triggered. This messenger RNA never enters the nucleus of the cell, which is where your DNA is stored, your genetic material is kept. Once the protein piece is made and the body has done what it's supposed to do, then the cell breaks down and the body gets rid of the mRNA. Does the COVID-19 vaccine have a tracking microchip? Well, there were videos that contain altered footage that's been widely shared on social media that's been fueling this microchip conspiracy theory. There is no microchip in the syringe that's being injected into your arm. The ingredients for each of the vaccines are clearly listed on the FDA website, and it does not include a microchip. Does the COVID-19 vaccine cause severe side effects? The most common side effects from the vaccine that's been reported are muscle soreness or swelling or redness in the arm where you get the injection. Other common side effects have been reported: chills, tiredness, headache, but we refer to these as expected effects. Your body is doing what it is supposed to do when it's building an immune response. So these are expected common effects. They go away in a few days. Some of them are more common with the second dose than the first dose. Although extremely rare, severe allergic reactions to ingredients used in the vaccine can occur. The vaccine does not contain eggs or preservatives or latex, which are common allergies that a lot of individuals have. Persons with a history of severe allergic reactions, those who have to carry an EpiPen with them and have had anaphylaxis reactions should consult and meet with their primary care provider to carefully go over the ingredients that are in the vaccine. Usually these individuals are watched a little longer after taking the vaccine. They're observed longer, but they're not contraindicated from getting the vaccine. Does the COVID-19 vaccine cause infertility in women? Again, misinformation on social media has suggested that the body attacks the protein in the placenta, which could lead to infertility. And this is not true. The antibodies that are produced do not attack or block the proteins that are in the placenta. Vaccines are not new in pregnancy. Women do get vaccines during pregnancy. The type you don't want to give during pregnancy is what we call a live vaccine. And so the COVID-19 vaccines are not live vaccines. However, we encourage that pregnant women weigh the risk and benefits. They discuss this with their OBGYN and that they're provided support in their decision-making process. Should I get vaccinated if I have already had COVID-19? And the answer is yes. Experts don't know how long someone is protected from getting sick after recovering from COVID-19. So the immunity that you get from having the infection, we call this a natural immunity, can vary from person to person. Because reinfection is possible, if you've had COVID, research has shown that you can have it again. It's recommended that people who have already had COVID get the vaccine. If you've had it, it's recommended that you wait until 90 days after your diagnosis to get the vaccine. Once I receive the vaccine, will I test positive for COVID-19? This, since there is no live virus in the vaccines will not affect your test results. However, it is possible to get infected with the virus after you've been vaccinated if you've come in contact with it before your body is fully protected. Full protection does not occur until 2 weeks after your second dose. And so that's why it's encouraged that you continue to wear a mask, socially distance yourself until you've obtained that full protection. Can I get COVID from the vaccine? You cannot get COVID from the vaccine because it does not contain the live virus. We're not injecting a little bit of COVID into your arm when you get the vaccine. So the answer is no, you cannot get COVID from the vaccine. Once I receive the COVID-19 vaccine, do I need to wear a mask? Yes. The best protection that we can offer each other right now is to continue to follow the current guidelines. I wear my mask for you, you wear your mask for me. So masking, hand washing, and physical distancing are all still warranted. As more people are vaccinated and more information becomes available on immunity, then public health experts will continue to update this guidance as necessary. If I receive the COVID-19 vaccine, am I at greater risk to become sick from another illness? The vaccine is made up of mRNA. You're not receiving a live virus. This mRNA is going to boost your immunity to the coronavirus, but it does not increase your risk to become sick from another infection like the flu. If I'm not at risk for severe complications of COVID-19, do I need the vaccine? We hear this from our younger populations who feel that, older people who have comorbidities are more at risk. So do they really need the vaccine? And the answer to this is yes. Regardless of your risk, you still can contract the infection. You can be asymptomatic and spread it to others. So it's important that you get vaccinated. Once the vaccine is widely available, it's recommended that as many eligible adults as possible get the vaccine. It's not only to protect you, but your family and the community as well. So our slogan that we've adopted from the Health Equity Task Force is wash up, mask up, separate, and vaccinate. It's not only to protect you, but your family and the community as well. So we know that the vaccine works, but it only works if we take it. Thank you for your time and your attention this evening, and I look forward to any questions that you may have. Thank you for having me.
Thank you, Dr. Brown. While we start the Q&A, we're also going to post a short poll on the screen to help us gather your feedback. So please take a moment to submit your responses. This really is very important in us planning for the future. And as I mentioned at the beginning, we hope to be back in business next year because we know that people really enjoy the health screenings that go on as well. So, Julie, do we have questions?
Yes, we do. Our first question for Dr. Brown, is it safe for breastfeeding women and their babies?
Yes. Can you all hear me?
Yes.
Yes. It is recommended that lactating women can take the vaccine, and it is safe for pregnant women as well.
And we have two people asked about the same question. Do we know how long the vaccine will last? Do you anticipate this being a yearly thing?
Well, that data is currently under investigation because the clinical trials for the vaccine started in July. So they're looking at that group that was in the clinical trials and studying them to see if they still have those antibodies for the full year. And we're getting our guidelines from the CDC and Dr. Fauci. And what he has recently reported is that his understanding is that the vaccine should provide immunity. There may be a booster that may be needed down the road, maybe several years down the road, but they're going to look at the participants who engaged in the clinical trials at a year's time, which will be in July of this year, to see if they still have the immunity. And if so, they will not need a booster or another COVID vaccination at that time.
We also had a follow-up to that question. Would it be necessary to remain with the same pharmaceutical company if an annual is required?
Well, what is recommended at this time, if you get the Moderna as your first injection, then you should get the Moderna for your second, because the Moderna and the Pfizer, although they do the same things, their ingredients are slightly different. We say it's like Coke and Pepsi. So if you're going to get the Moderna first, you should get the second dose as a Moderna. Same for the Pfizer. Now, J&J, the Johnson & Johnson, is supposed to be obtaining FDA approval and for emergency use, I believe it's going to be the first week in March. And that's a 1 injection. And it should provide 80%, 85% efficacy. So with that one, you'll only need that 1 injection.
Our next question is, what about all those variants that are in other countries and coming to the US? Do the current vaccines prevent that? And if so, how effectively?
Well, again, I've been listening to the national database, and the scientists are saying they're not losing any sleep on that. They feel very confident that the vaccines that we currently have are safe against those variants. But as more information unfolds, then they will provide us with that information. But currently, they strongly believe that the current vaccinations that we have are safe and will safely protect our individuals from those variants and those mutated viruses.
Our next question is, there is some hesitancy about the vaccine, and I've heard that a fairly large percentage is among healthcare workers. Why is that?
That's interesting because we've been targeting focused groups. We've had LDH is holding conversations with healthcare providers, with nurses. There was a forum today about conversations with nurses. The research has shown that individuals that are considered trusted voices are going to be your physicians, your nurses, your pharmacists, and your faith-based leaders. Those are the individuals that research has shown that people consider trusted voices. And so the message that we're trying to communicate is to reduce vaccine hesitancy and to promote vaccine acceptance. And what I'm hearing in talking with just focus groups is the healthcare providers are sort of, they want to wait and see. And so as they're seeing more and more individuals getting the vaccine, we're seeing an increase in that vaccine acceptance and a decrease in the vaccine hesitancy. And so we're exploring it. And I think it generated from just a wait and see attitude towards it is my understanding.
Thank you. Our next question is, how long should you wait between the COVID-19 vaccine, the flu vaccine, and the shingles vaccine?
It's recommended at least 14 days that you wait between vaccines. And of course, if you've had COVID, that you wait at least 90 days. So that's been the recommendation before you take a vaccine.
Is there a timeline for children to take the vaccine, ages 10 to 15?
Well, currently, the vaccine has not been approved. The participants for the Pfizer included individuals that were 16 and older. So 16 and older are approved. For Moderna, it's 18 and older. So they're looking at children under the age of 16 to participate in clinical trials so that we can obtain, safety data and efficacy data on that age group. But at this time, individuals under the age of 16 have not been approved to receive the vaccine.
Dr. Brown, do you know if there is a registration link to get vaccines at Southern University?
What we're proposing right now, what we have in place at Southern is we are in partnership with an FQHC, Care South, and that's specifically for our tier groups, for our College of Nursing and Allied Health faculty, staff, and students. So we're following the tiers, the 70-year-olds, employees, and then our 55 to 65-year-olds with those comorbidities. So right now, it's specifically for our employees, our students, and faculty. But we are engaging in some dialogue with, we did hold a mass community vaccination at the Mini Dome, which was very successful. And so we're looking at bringing those vaccines back to heavily populated minority areas so that it would be easily accessible to those communities. This weekend, as a matter of fact, tomorrow and Saturday, LDH is partnering with Living Faith, which is a African-American church on Winborn. And so we're launching, we realized early on that there was some inequity in the way the vaccines have been distributed. So we want to make sure as a task force that the vaccine is distributed equitably and accessible, particularly to communities of color that are most vulnerable to the virus. And so every week for the next 4 weeks, vaccines will be brought into North Baton Rouge, partnering with African-American churches. And you can go to the LDH website and the Council on Aging to register.
Thank you for that information. Another question we had was that I've heard that people with severe allergies were not part of the trials, and some individuals are concerned about that. Should they be?
It was my understanding that there were individuals who had severe allergies, who had, EpiPens, That's how the data was supported, that they are not excluded from the trial or from being eligible. All that is said is if an individual has had anaphylactic reactions, to consult with their primary care provider to look at the specific ingredients in the Moderna and the Pfizer to ensure that they're not allergic to those specific ingredients. But individuals who've had anaphylactic reactions to eggs or peanuts and they carry an EpiPen, they are not excluded. They will just be watched longer. Usually we watch our patients for 15 minutes after they get the vaccine, but if they have a history of anaphylactic reactions or carry the EpiPen, then we watch them for 30 minutes. If there's going to be a reaction, it's going to occur within the first 30 minutes to an hour.
The next question we had, you don't hear much anymore about testing. When should you get tested?
Well, we are still encouraging testing until we can get what we call herd immunity. The best way to contain this virus. This is a virus you can't see, smell, or hear. It's there. You can't look at someone and say they have it. So the best way of mitigating this is for testing, contact tracing. So we still highly encourage individuals to get tested until we can safely reach herd immunity, which is about 80% of our population. You heard earlier, one of our speakers, I think it was Dr. Thomas, said that we're at 14%. That's still, we've got a long way to go to achieve that 80% of herd immunity where we can return to some sense of normalcy. So testing is still very, very much encouraged.
Do you have any advice for children on what they could tell their parents who are nervous about getting the vaccine?
Do it for you so that I do it for you so you could do it for me. What I tell my family is first, I too was hesitant in the beginning. When they talked about warp speed, that's a terminology that just frightened me because it presented a misnomer or misconception that this was done hurriedly and rapidly. And then when I delved into the science and saw that no steps were skipped and that, everything was done in proper order, and I looked at the results from the clinical trials, then I knew that the vaccine was safe. I am fully immunized. I took my second dose on Monday. My husband took his today. And as soon as my two college kids, or it's their turn, they're going to take it as well. This is the only way that we can get a handle on this vaccine, on this virus, is by taking the vaccine. It works. We've looked at the plummeted numbers of cases just in the nursing homes because they were the first group, high-risk group, to receive the vaccine. And those number of infections are way down. So we know that the vaccine works, but it only works if we take it.
Thank you. Our next question, is it recommended to get tested even if the second vaccine has been received longer than 2 weeks following the second dose?
Well, if you've received the second dose, you reach full immunity, you're protected at 2 weeks after receiving the second dose. Now, there's still that small window, that 5% chance that you could be positive if you come in contact with someone who's positive. But what the vaccine does, it prevents you from getting sick and from having to be hospitalized. It prevents you from getting those symptoms. And so that is how we can control the rate of hospitalizations and death.
We also had a question. Do you know why some facilities are charging for the COVID test?
The COVID vaccine is free because the government has paid for it. Now, some places may be charging an administration fee, like a fee for the nurse to give it. But the vaccine in and of itself is free. If they are charging it, then, you know, we need to know about that. But every community-based clinic, every FQHC, every pharmacy that I'm aware of, there should not be a charge. Now, an
They're actually
independent,
asking about the COVID test, not the vaccine.
oh, the test. They are, some places do have a fee affiliated with the test, and some places don't. There's been some inconsistency with the how that's being charged. I myself went and had a COVID test at an urgent care clinic and had to pay my what is it you call your copay.
And then our last question, I think, that we have for tonight, with the differing effectiveness levels for the different vaccines, is it possible to choose which pharmaceutical company?
At this point, no. The Pfizer is primarily, if you're going to get if you go to a hospital setting, the chances are that you'll probably get Pfizer, because Pfizer has to be stored at those subthermal temperatures, very, very low temperatures. And I just read something yesterday that might be changing. But so hospitals who have these sub-zero freezers are more like they have the capacity to store the Pfizer. If you're going to go to a pharmacist or a community-based clinic, you're more likely to get the Moderna. Now, as far as the Johnson & Johnson, I'm not clear on, you know, because that has not been fully approved yet. So we're not real sure how that will be allocated. But there's been some conversation that the Johnson & Johnson probably would be most suitable to give when you do mass vaccinations, like they're doing a mass vaccination at the Morial Convention Center in New Orleans. That would be a classic opportunity to use the Johnson & Johnson, because it's a one injection and you can vaccinate a large number of people without having to have them come back for the second dose. So that's been the dialogue of where these vaccines may be allocated. It's going to be based on a number of variables: storage, you know, freezer capability, and if it's going to be a mass type of vaccination event.
That concludes our questions for tonight. Thank you so much, Dr. Brown, and everyone who participated. We had excellent questions. Now I will turn it over to our fearless leader, Dr. Kathy Champagne, for a few closing announcements.
Thank you. Thank you for having me.
And Dr. Brown, I want you to know that I'm 1 week, I've had my second dose a week ago today, so I've got another week to go.
And you'll be fully immune. That'll be a great feeling.
I'm feeling good about that. And you know, I had no reaction. So no reaction for the first, no reaction for the second. So I feel blessed.
That is great. That is great.
But thanks, Julie. The one thing I want to mention is, if you have not completed the poll already, please take a moment to complete it now. We're going to post the recordings from tonight and Tuesday on our website within the next 2 to 3 weeks. So we again thank you for joining us. We hope you have a great evening, and we hope to see you all again next year, hopefully in person. So thanks so much.